Hello, everyone. Thank you so much for joining us today for our webinar, Making the Mouth Body Connect. Wait, let me say that right. I want to make sure I got it right. Making the Mouth Body Connection in Cancer Care. This webinar is part of our Survivorship Champion Series, which is our program for clinicians and researchers who are interested in improving survivorship care. Of course, we welcome anyone to participate in the webinar, and we have a lot of advocates and survivors who've joined us. We're really honored today to have Jill Meyer-Lippert, who is the CEO of Side Effects Support, to join us to share her expertise in oral health and some of the underappreciated, under-discussed aspects of cancer care, that the effects on oral health and some of the preventive strategies. She's a registered dental hygienist, and she comes to this work through family connections to cancer and seeing some of the side effects that her family members dealt with. And she has a really great presentation for us today. Before we begin, I just want to say you can use the chat box or the Q&A to ask questions, and you can also use the chat. I'm not going to go into her entire bio. It's on the registration page, and also we're going to put a link to her bio in the chat, but I want to make sure she has enough time to talk. We will be sharing the presentation afterward, so you will be able to have the slides and the video. And then also just a reminder that we can't address individual medical questions. I think she can talk broadly about some of the connections between treatments and cancer, but we can't answer specific individual medical questions in this presentation. So Jill, thank you so much for joining us today, and I'm going to turn it over to you to begin your presentation.
Sounds great. Thank you. I'm going to pull up some slides. So I really appreciate the opportunity to join you all today, and for everybody that's taking the time to be part of this. I do want to just take a couple minutes to really give you more of a background. What in the world is a dental hygienist being involved in oncology for? And I started my dental career back in 1992 as a dental assistant while I waited to get into my dental hygiene program. And at almost that exact same time, my mom had announced that she was diagnosed with breast cancer, and her cancer was followed by a mastectomy and what was supposed to be 6 months of chemotherapy that ended up being 7 with delays from complications. And she suffered horribly with all sorts of side effects from her chemo, but especially side effects in her mouth, where she would choke from her tissue sticking together because her mouth was so dry. But she did hurt to even drink water because she had these huge mouth sores. And I so clearly remember her feeling so defeated when she asked her oncology team, "What can I do? I'm in so much pain." And at that time, they basically shrugged their shoulders and said, "It's just part of treatments. You need to deal with it." And I found that very difficult to accept. And I very foolishly thought that now that I worked in the field of dentistry, I was going to save the day. And it didn't take long to have the reality that was not the case either. It was, you would think, being the mouth as dental professionals, we would know what to do. But information was very sparse. And especially in the early 90s, it's not like you can hop on a webinar. It's not like you can Google for the information. So there was a lack of information available. And I really decided that my best way to learn more is to question patients at the practice where I was working at the time. So everybody who came in with cancer in their medical history was an opportunity to learn. And I would question, what kind of cancer did you have? What kind of treatments did you have? Did you have problems inside of your mouth? What did or didn't help you? And it didn't take long to start noticing some patterns where not everybody had problems inside of their mouth, but a lot did. And for those who did, very few felt that they were adequately prepared for what they were going to be dealing with. Of those, even fewer reported that they were provided any type of guidance of ways they could possibly prevent or manage the issues. But what I found most surprising is how many people got through their cancer treatment successfully, only to have a lot of damage done to their oral health. And they went from a situation of all this time, stress, and money in an oncology setting, and they basically transferred it into a dental setting. And for some of these people, they were dealing with trying to repair the cycle of damage inside of their mouth for many years after their treatments were complete. And for some, it seemed like a lifetime, depending on what their treatments and type of cancer was. And it really became obvious there was a disconnect between the medical field and the dental field that was not only leaving our patients with an inadequate amount of information, but also sometimes inaccurate information that was making the problems worse than they really needed to be. And my golden example for every presentation that I do is I had a long-term patient that had been a 20-plus year breast cancer survivor. And unfortunately, she had a recurrence where it had metastasized to her bone. And the type of treatment she was receiving, I was allowed just to continue seeing her for her regular recare appointments. And when I had that opportunity to see her back that first time, of course, my first question is, are you having any problems inside of your mouth from your treatments? And she said, oh, yes, my mouth is so dry from my medications, but it's okay because the nurses told me to suck on lemon drops. And that really seems like it's helping. And I was absolutely shocked. From a dental perspective, that is one of the worst things that you could recommend for a xerostomach patient, somebody who's so susceptible to decay and infection. But then I realized that that was a pretty common recommendation. And to this day, I will hear that sometimes is still being recommended, or there might be an infusion center that's leaving out Jolly Ranchers, lemon drops, things like that for their patients to suck on during infusion. So we've come a long ways since 1992, but we still have a long ways to go. Fast forward to my dad eventually being diagnosed with Hodgkin's disease. And after he passed away, I really felt the need to take some of these bad experiences and make something good come out of it. So one of the things I did is create a volunteer program at a local oncology department where everybody who started chemotherapy or radiation to the head and neck was provided with a goodie bag, and it had information that I had designed with side effects that may occur, simple tips of things they could do to hopefully minimize the issues, and then sampling of products. And I kept that going pretty strongly between 2006 to 2012. And by the time 2013 rolled around, I had decided to expand the reach, knowing this was not just a local issue, this is a worldwide problem, and created my resource called Side Effect Support. And I really modeled it around what I wished I would have had when I wanted to learn more. So it's a source that patients and family caregivers can get free information easily, but also medical and dental providers to help get us on the same page. So we're giving consistent recommendations to our patients. So please keep your phones ready. I do have a variety of QR codes in here that will have free downloads for extra information that you can take home. The picture on the little cell phone there, that is me and my mom. I'm happy to report that she did get through her cancer treatment successfully, and we will be celebrating her 86th birthday this year. So our objectives really are to identify some oral systemic links with various types of cancers, describe oral side effects of treatments and how they not only affect quality of life, but possibly even treatment outcomes, discuss preventive approaches to avoid and manage short-term and long-term oral side effects, and then develop some strategies for better collaboration between the medical providers and dental providers. So there are some hospital systems that have implemented very simple oral care protocols that are really getting some amazing results. And I just have a couple headlines from some magazine articles here. This one from Modern Healthcare magazine that highlights a program at Johns Hopkins All Children's Hospital. My understanding is this was actually a collaborative effort between a variety of different children's hospitals, but it was based around providing an oral care bundle, similar to probably what I had provided, providing instructions for the nursing staff. First of all, helping them understand the importance, and then helping them to relay that information to the patients and the patient's parents and provide proper oral hygiene instruction. And they were pretty simple: brushing teeth and lip balm twice a day and using a mouth rinse 3 times a day. As far as what the mouth rinse was, it appears that this may have varied from one facility to the next. So it's a little vague in the story itself. They estimate they had a compliance rate about 60%, which is phenomenal. It's hard enough to get children who do feel well to brush their teeth. But with that, they had a 50% reduction in mucosal barrier infections. They noticed that fewer children were going to the ICU. They had children being released earlier. For children that were released and the parents reported that they were following through on that same oral care routine at home, they had fewer kids being readmitted for infections. And then this is a award-winning program out of Sutter Medical Center in Sacramento. It's actually called the HAPPY program for the same type of thing, looking for ways to reduce infections. In this case, they're looking at non-ventilator hospital-acquired pneumonia. It is a nurse-led program. One of the nurses is a researcher that they trained again to have the nursing staff, first of all, understand the importance, to be able to provide instructions to the patients. If the patient is unable to provide their own oral hygiene routine, the nurses were trained to provide that for them. And this was a program that between 2016, 2017, they've noticed a dramatic reduction in hospital-acquired pneumonia cases with a huge savings compared to what they were investing with these modest oral care bundles. So this is a great spending savings for a facility, but more importantly, the lives that have been saved, the quality of life that has been saved by something so simple as just keeping their mouth clean. But the sad reality is oftentimes in inpatient situations, especially long-term care facilities, oral hygiene is something that often falls by the wayside. And we have a lot of work to do with this aspect. So there are many oral systemic links. There's just more and more that's being learned about how oral health is related to other systemic illnesses. For many years, oral health's been related to cardiovascular disease, to pregnancy complications, obviously respiratory illnesses. And most recently, they've made some connections between certain oral bacteria and Alzheimer's disease. So cancer is actually no exception to that. There are more and more studies coming out where, they don't always know exactly what that link is, but they are feeling some pretty strong connections between having oral disease and having higher risks for certain types of cancers. And this is just a collection, again, of some headlines that is exciting that they're actually isolating specific oral bacteria, most often associated with periodontal disease, embedded in certain types of tumors. So this is exciting because it really is going to provide us, as we continue to learn more, identifying which of our patients are at greatest risk. We can figure out different ways, modes of prevention, different treatment options, and possibly ways that having the treatments more successful. That is something where we have the ability now that we can do oral microbial testing. We can get a full panel of exactly what type of bacteria are making up that patient's mouth and the percentages. And there are actually some home tests that patients can do this on their own now, and then get customized recommendations of things that they can do to help improve their oral microbiome. So my battle cry for every presentation is that early intervention and patient education really are the key aspects of trying to keep oral side effects under control. And if we can, in the dental field, if we have the ability to see that patient early on in the process, and I always usually call that the golden window, where most people, unless you're dealing with a blood cancer, you're going to have that time where you have a time span between diagnosis and actually starting the treatment process, where they're going to be dealing with suppression of their immune system. And if we can see that patient during that specific time, that is when we have the greatest potential for making a difference for them during their treatment process. So that is where we can put our detective hats on a bit, and we can look at their medical history, look at their current diagnosis, look at their treatment plan, and combine that with their dental history, what we're seeing in their mouth at that particular time, their motivation level for oral hygiene and follow through. And if we put all those things together, we can get a pretty good idea of what they're going to be at risk for. And then if we know that those problems are a potential, taking action before they start. Once a problem starts, it's much harder to get under control. And then we're in a situation where we're trying to put fires out. And even if we can't avoid the problem altogether, even if we can delay the onset within the treatment process, or reduce how severe it gets, that is a benefit for that patient all the way around. So some of the oral health risks, and of course this, I'm sure there's more than this, but these are going to be things that that patients most often will be dealing with, as far as, the dry mouth, the oral mucositis, and all of the problems that can result from that with the dry mouth, the caries, which is dental decay or cavities, the periodontal disease, which is a disease involving the support structure of the teeth. It can involve enamel erosion. And then even when we get down to these more complex ones, like the osteonecrosis of the jaw from certain medications, the graft versus host disease, oral health can play a huge part in how much of an impact and how much at risk that patient will be for these issues. So I do have an oncology intake call sheet that I had designed that you're welcome to use this. This was just a simple guideline that I had created, that if there is communication between the dental team and the medical team, something that can be used by the, whoever is making that call, whether it be a clinical team member, an administrative team member, to kind of guide what is helpful for us on the dental end, to make sure that we are not only treating that patient safely, but doing it efficiently, that we are not going to be playing a part in delaying that treatment process in any means. So when we have the ability to see that patient early, that is one of the keys. Is, the dental provider needs to understand that they need to see that patient as soon as possible, because if there is work that needs to be done, we need to have the time to complete that before they start their immunosuppressive treatments. It's important that we take thorough records and ones that are specific to treatment needs. I think a great example of that is if we have somebody that's going to be going into head and neck radiation therapy, and we believe they could be at risk for trismus. Well, that would be a patient we want to take recordings of their jaw mobility. We want to record their maximal incisal opening. We want to look for their lateral excursions and make sure we have a baseline. So we have some documentation that if there is damage that occurs, that it is documented, because that can help that patient potentially have some coverage for repairing some of these the damage, or having treatments for it afterwards. And our main goal is really to just get them in a basic level of health, make sure they're not entering into treatments with any active decay, any infection, anything that could compromise their treatment process. If you have somebody that comes into the practice and they just have too much work that needs to be done, there's no way that the dental team can possibly get all these restorations done before they are to begin treatments, and we don't want to delay that treatment start for them. There are options now for non-invasive ways of restoring caries or repairing cavities. This is a non-invasive caries therapy guide from an organization called CareQuest, and you can access it through the QR code. And now there is a CPT code that is in effect that does allow medical providers to implement one of these non-invasive procedures called silver diamine fluoride, which is basically a gel or a liquid that can be painted over the cavity, and it will bind those silver ions to the cavitated tooth structure, and can actually stabilize that. And that can hold that patient over potentially until they are more medically stable to go back and have more thorough restorative treatments done. So this is a great option for our medically compromised patients, especially patients that are in the treatment process. And now we don't want this cavity to develop into an infection. It's maybe not safe for them right now, blood count wise, to go into the dental practice. This is something we can do to help hold them over. It's just good to be aware that silver diamine fluoride will stain any weak tooth structure or any cavities black. So aesthetics do need to be considered, but of course, if it's something that is just an appearance issue that still stabilizes them while their blood counts are low, that is a great option for them. And then if we know that a person is at risk for certain side effects, we can start taking action before they start. And this is something where the patient education really comes into play, because it's hard for people sometimes to understand, well, I'm not having this problem right now. Why do I need to make these changes? But if they know, okay, this could happen, let's just take some action. Maybe we can avoid it. Maybe we can minimize it. Maybe we can delay how soon it starts. And that is a good motivation for them to start making some simple changes at home. We can provide them information and resources and informing without frightening. Obviously, we don't want to start going into details about certain things that would make them not want to pursue their treatments, because just because it is a risk doesn't mean it's going to happen for sure. But it's so important that we keep lines of communication open between the oncology team and the dental team. And unfortunately, that does not happen very often in many areas of the country. There are certain facilities that are great, that they have a full care team that is working together and providing care from all different aspects. But for a lot of people that are getting their treatments in more rural settings, they may not have any of those extra professionals and to depend on to help with their specialties. So I did create some patient education pamphlets that are free to download on my website from the resources page. I do have an adult version, and I also have a child's version in English and in Spanish. I'm hoping to expand that into other languages at some point, but this is just a guideline, again, of simple tips of things they can do to prevent or manage some of the issues, and just so a little easier communication. So as far as patient education goes, it's important that our patients understand that dry mouth is so much more than a comfort issue. Our saliva is actually amazing, and it plays a role in tissue lubrication, so it helps to avoid wounds from occurring. If a wound does occur, there are elements of saliva that help with healing. It helps prevent bacterial, viral, and fungal infections. It helps to buffer oral pH, and that's something we're going to talk more about, and how oral pH is related to the demineralization and remineralization of teeth. It's our first step in food digestion, and it also does play a role in taste. There's certain taste buds on our tongue that are dependent on saliva to function properly. So people that have a really dry mouth are going to be more apt to have taste changes. Simple tips that they can implement right away is staying hydrated, making some dietary changes, avoiding drying diet choices like caffeine and alcohol, dry, crusty foods, and using lots of sauces and gravies to keep their food choices moist. Breathing through your nose, which is such a simple thing, but that is something that some people are just mouth breathers by habit. And they've maybe never been told that there's a saying in dentistry, lips together, teeth apart. You don't want them holding their teeth together in order to keep their lips, their mouth closed. But if they keep their lips closed, really concentrate on breathing through their nose, that's going to help to keep those oral tissues moisturized. And for some people, that may be difficult. Maybe they have some sinus issues. So for them, maybe a simple saline nasal spray may be enough to keep those nasal passages moisturized, to keep breathing through their nose more possible. If we have a mouth breather, we can do all of these other things. And unfortunately, we will be going in circles with trying to keep their mouth moisturized. And then, of course, using a humidifier, especially at night, to keep their air moist too. There are a lot of prescription and over-the-counter dry mouth products on the market. And this list is growing because the companies, the market is recognizing that with the baby boomer area, and having a society that takes a lot of medications, there is a big, big problem with dry mouth. And so companies are recognizing this. They know it's a huge market. The things to keep in mind, there is no one size fits all. So you will have a product that works fabulously for one person, doesn't work for the next. Or you may have somebody that they really like this product, it helps them at this particular time. Then their medications change, their body chemistry changes, and now that product doesn't work as well. So it's good for patients to be told, just be open to trying different things. Just because, you tried 3 things and you didn't feel they worked that well for you, don't give up. There's something that's going to help down the line to work better for you if you just keep trying different things. But also think of long-term effects, not just masking the symptom. There are products on the market that I would compare them to using the lemon drops. They're going to make your mouth feel some relief as far as the dryness goes at the particular time. But with continued use, they can actually contribute to tooth damage. And we'll go into some of why that is. So it's helpful to understand oral pH. A healthy mouth is ideally around that 7 range, which is your neutral range. And every time that we eat or drink anything, our oral pH plummets down into a more acidic low range. And then it takes the healthy elements of saliva, the calcium, the phosphate, the bicarbonate, to bathe that oral environment again, and then buffer that oral pH. So it'll raise it up into the higher numbers again. And if you look at that tooth, we're just going to do a little review on tooth anatomy. A tooth is formed in layers. So that outer layer is considered is your enamel, and that's the hardest part of your tooth. Inside of that is the dentin. It's softer. And inside of that is the pulp. It's the area of the tooth, the center where blood vessels and nerves enter the tooth, and that's what gives the tooth life. So when we start having breakdown of tooth structure and a cavity forms, we want to try to find it as early as possible when it's in that hard outer enamel shell. If it breaks through that and gets into the dentin, now that structure is softer, so now it can grow faster. If it gets into the pulp area, that's where we as dental providers are really limited on what we can do to help repair and try to save that tooth. We have an option of doing a root canal treatment where we can make a little hole in the tooth, go through with files, remove all the nerves and blood vessels, and then put a filling material to fill that pulp chamber up. Or we can extract the tooth. Those are pretty much our options. So when we look at, though, that demineralization and remineralization, I'd compare it a lot to just how our bones continue to remodel every day throughout our lifetime. That is what teeth do as well. So when we look at those shells of the tooth again, that enamel, it has what's considered a critical pH, and that's where it takes getting down to the certain pH before we start having breakdown of the tooth structure. So that outer shell is about a 5.5. And the softer dentin on the inside is about a 6.5. And then the cementum, which actually coat our root structures, is about a 6.7. So it doesn't take much for a drop in our oral pH to start having breakdown of those areas around the root structures. And that's why so many times we see people who have dry mouth that get cavities on the roots, and they get sensitivity on the roots because it's so much more susceptible. What we can find, though, is that those are considered kind of your standard numbers. But if somebody is already having dry mouth issues and they don't have that healthy calcium and phosphate to do the buffering, it can take less of a drop in their oral pH to have that breakdown of the tooth structure, and they kind of stay hovering in that acidic state inside of their mouth. So knowing that, it's frightening that some oral care products on the market are actually acidic. This is a study out of the University of Florida in 2018. They studied 11 dry mouth lozenges, and out of the 11, only 2 were considered in a safe range. And again, we want to keep products preferably into that as close to 7 neutral as possible, possibly even into the alkaline range, those higher numbers. So you can imagine somebody that already has a very acidic environment from their dry mouth, and then they're holding an acidic product inside of their mouth, how that is going to eventually contribute to tooth damage. And this is a list of some various mouth rinses. And with this list, I want to put a little disclaimer there to take it with a grain of salt because products change. You may have a product that keeps the same formulation, but they rebrand the name, or they keep the same name and they make a whole new formulation. So these lists can be accurate at one time and they may not be accurate at another time, but it's just a good visual that to see, where are some of those ranges, and that red line is kind of where we want to try to target close to or above it. And that's something, if you are recommending products to your patients, do some investigation and find out what the pH is. There are also sweeteners that are used in certain oral care products that are beneficial for teeth and helping to prevent cavities and reduce specific types of negative bacteria inside of the mouth. Xylitol is a natural sugar substitute. It is something that's found in different berries, and it has a different carbon structure than regular sugar. So it looks like sugar, it tastes like sugar, but because of this different carbon structure, the bacteria in our mouth that typically would eat the sugar when we are eating fermentable carbohydrates, and then they convert that sugar into an acid, that's how cavities are created, they cannot digest this. So with regular use, and typically the recommendation is 5 exposures a day, 6 to 10 grams a day, you can actually cut down on those specific oral bacteria inside of the mouth. Plus the sweet flavor can trigger the brain to help produce saliva. It is digested as a fiber, so you need to introduce it into diet slowly, because if somebody has never used xylitol before and all of a sudden they use xylitol in large quantities, they can get like a laxative effect with that. It has a low glycemic index, so it is safe for diabetics, but you do want to keep it away from pets because just like raisins, grapes, chocolate is fine for us, but not for our dogs. The same thing with xylitol. They can get very ill if they get into your xylitol products. Erythritol is another sweetener that works in much a similar way. And it helps to also buffer the oral pH, reduce certain types of negative bacteria inside of the mouth, but there's not as much of a laxative effect with that and not as much of a risk for our pets with erythritol either. So this was a study in 2020 where they took 2 groups of children that were going into stem cell transplants and had them both follow an oral care routine. For one, it was, one of them, they added a simple xylitol wipe. So besides their brushing and their rinsing and their lip balm, things like that, they had a simple wipe that just would be run over their cheeks, their teeth, their gum tissue, and they found a nice improvement in how many kids had bloodstream infections. So the group that did not use the xylitol wipe had, I believe it was 4 bloodstream infections, where the one that did use the xylitol wipes did not have any. So, is xylitol a magic bullet? Maybe not, but again, is this something so simple that we can do that has the potential to make a big difference for our patients? And I think the study is just an encouragement that they will be looking more into this and the effects that it can have on improving the microbiome in general. And of course, with oral mucositis, we tend to go through that roller coaster stage where the tissue will look healthy, then the immune system is called into play because of the cell damage, cell death. Then you start having the oral ulcerations. And by the time that you actually see those ulcerations, you're already technically moving into that healing stage at a cellular level. So once you're in that healing stage, though, it may look normal, but the tissue's been changed. So now every time that patient would go in for another chemotherapy infusion, another treatment, they're that much more likely to have oral mucositis occur. They're just that more likely to have it be that much more severe. And that's why, again, if we know somebody is at risk, we can take steps to hopefully delay that from starting. There are certain risk factors that we have no control over. Obviously, the extremes of age, the extremes of body mass index, females are more susceptible to men. And depending on their specific diagnosis, their specific treatment, that is what's going to make a really big difference if they're going to be at risk for oral mucositis. But there are things we can modify. We can treat their dry mouth. A dry mouth is going to be more likely to ulcerate. We can deal with any existing dental issues before they start their treatments, and that could be something like adjusting an ill-fitting partial or denture, doing a restoration to remove a food trap, a sharp cust on a tooth, anything that can initiate that inflammatory process. And poor oral hygiene. Somebody that has a lot of dental plaque buildup is more likely to develop oral mucositis. So it's important that they understand the effects of cleaning their mouth and how important that is to reduce their risks. So we're going to go into, after this, some simple tips of oral hygiene and things that people can do to help minimize their risk. And some of them are really, really simple. But this is also just highlighting that the oral microbiome may actually be connected with the severity of oral mucositis in some cases. And this was just something that had come out in October, which again, if we can work with improving that makeup of the microbiome, we can help to reduce their risks. For patients, many times magic mouthwash is kind of it's a go-to. This is something that there's so many different recipes for magic mouthwash. For some people, it is a game changer with comfort, is a game changer with helping them to be able to continue eating. The negative parts of magic mouthwash is that many times they are very sticky. There's sweet components with that in the long run, there may be some negative effects for oral health if they are using it for an extended period of time. So this is to not say that magic mouthwash should never be used. It has its place for sure, but there can be times where it seems like it's almost a knee-jerk reaction, and people are automatically given magic mouthwash no matter what their problems are. I've heard it actually in some seminars being recommended for dry mouth, and there's nothing in magic mouthwash concoctions that would actually be an assistance for dry mouth. And in those cases, if that's what it's being prescribed for, it could actually make problems worse for them. There are some baking soda and salt water rinses that are pretty standard as far as being recommended for patients. This particular recipe is recommended by the International Society of Oral Oncology, where it's basically a teaspoon of baking soda, a teaspoon of salt mixed with 4 cups of water, putting it in a closed container, mixing it up, and just using it throughout the day. At the end of the day, dumping that out, and then the next day making a new container. But there are several different recipes. This is just one option. And this is also the recipe that I do have in the side effect support patient brochure. So we're down to the very simple things, the nitty-gritty of what patients can do. The first thing is really looking at the size and the shape of the toothbrush. So I do have some visuals here that for many people, when they go into a big box store, they go into a convenience store and they get a toothbrush, a lot of times they're huge. They've got a big head. A lot of times they have medium bristles, hard bristles, and it's ideal for our patients to use an extra soft, compact head toothbrush. A smaller head with extra soft bristles is going to make continuing to brush easier if their tissue gets sore. It's going to help to reach into the hard to access areas with reducing risk of toothbrush trauma. There are all different sizes. There are specialty brushes that even a child-sized brush is a great option for some people to make sure that they can access areas, making sure that they can keep that bacterial plaque off of their teeth. Softness of bristles, like I said, you want to use an extra soft, compact head. The softer your bristles are, the faster those bristles are going to wear out, and they should replace the brush at the first sign of bending or fraying. So they may be replacing their brush far more often than what they're used to, but that is good because then that brush is not having a chance to build up bacteria on that. we think of how it's important for patients to also protect their toothbrushes and be just protective of their oral hygiene products in general, so they're not transferring germs from one patient to the next. So oftentimes you'll go into people's bathrooms and you'll see everybody's toothbrushes sitting in a cup together, out on a counter, maybe near a flushing toilet. That is a great way that anything that's floating around your bathroom can end up on your toothbrush. This is a great way if toothbrushes are touching, that whatever is on this family member's toothbrush can be transferred to this family member. And that is something that if we have a healthy immune system, is it that big of a deal? Probably not, but for somebody whose blood counts are very low, this is a way that infection can spread between family members. And just like they should not be, sharing a toothbrush, they should not be sharing lip balm, they should not be sharing unwashed utensils. One thing I do recommend is also using their own tube of toothpaste. If anybody thinks, especially if you have children, if you take a tube of toothpaste and put a ribbon out, a lot of people will take the end of that toothpaste tube and touch the bristles with that, and now technically the end of that toothpaste tube is contaminated, and you can transfer whatever's been on that brush to other family members as well. So just keeping their items separate can be one extra thing they can do. Looking for detergents, examine their toothpaste, especially for what kind of detergents in there. One of the most common that you're going to see is a sodium lauryl sulfate. That is a sudsing agent, is found in a lot of bath soaps, laundry detergents, dish soaps, and it helps to give that toothpaste this nice foamy consistency that you really feel like you're cleaning well. But unfortunately, sodium lauryl sulfate is known to be a skin irritant for a lot of people. This is one of the ingredients that if we have patients in the practice that would come in with chronic canker sores, chronic aphthous ulcers, or having burning mouth syndrome, problems like that, one of the first things that we would recommend is cutting out products that have sodium lauryl sulfate. It's amazing the difference that can make. Another one to look for is cocamidopropyl betaine. I'm seeing more and more products that are coming out that will advertise as, hey, we're sodium lauryl sulfate free, but they've replaced it now with cocamidopropyl betaine, which also does have some evidence of being a tissue irritant for some people. You may have somebody that has never had a problem with one of these chemicals before, but now they're at risk for oral mucositis, and this is one extra thing they can do to help reduce their risks. Also, avoiding any drying and irritating ingredients like alcohol, phenol, whitening, tartar control. Those can be very irritating to tissue. And considering flavors, mint and cinnamon can be much too sharp and sting the tissue for many people. Sometimes you may have a mint that is a much different strength than the next product's mint. There is a range for that, but there is also, there are different unflavored toothpaste and oral care products out on the market for people that do struggle with flavors. And sometimes using a child's flavor like a berry, a bubble gum can be much more soothing for patients. And as far as cleaning in between the teeth, if your patient is not a flosser prior to starting treatments, during the middle of treatments is probably not the time for them to start with low blood counts, because proper technique is a must, and it takes practice to have the proper technique with flossing. And I'm just going to give a quick demonstration with this. It's important that everybody talk with their dental hygienist to make sure their hygienist tells them how to do this. But if you take about an 18-inch string of floss, wind it once or twice around the middle finger of one side, all the rest on the middle finger of the other side. That'll give you your pointer finger and your thumb to have more extension to the back of your mouth and have better control. And if you have your elbows down to fulcrum yourself, you'll have much better control and not risk tissue trauma and slipping and jamming it up into the gum tissue, which is more likely if you have your elbows out, it's harder to reach and you're more likely to slip and damage the tissue. Right, like it shows in the picture, when you go in between the teeth, you want to curve it and make a C shape that you're hugging one of the teeth real tight. And then you can go back and forth a little bit, but ideally you want to take that floss in an up and down motion that you are scrubbing that whole inside edge of the tooth to remove any plaque that's sticking on that inside edge. And as long as you're curving it real tight, you will slide in between the tooth and the gum tissue where there is a natural space in there. And that'll help to drag out any plaque that collects in there too. Once you do it on one side, then you flip it over to the other tooth and you get the inside of that edge. And when you pull it out, you can wind around the use area and keep going to the clean spot of the floss as you go through. And that way you're not getting plaque and food debris just transferring from one area to the next. Flossing always has to be done in respect to blood counts. And that is something for on the patient perspective will most likely be informed by their oncology team if they are at unsafe levels to floss. And the same thing goes with any of the other tools that are available. There are a lot of tools that make it a little easier dexterity-wise to clean in between the teeth, disrupt that plaque that's sitting on there. But that, again, does need to also be done in respect to blood counts. As far as fluoride goes, that is a gold standard in dentistry yet as far as trying to keep tooth structure healthy and strong. There's a difference between topical fluoride and systemic fluoride. The systemic fluoride, really like in a water supply in the city, that is going to be more of a benefit for children as their teeth are forming, where topical is going, once your teeth are formed, topical is where you're going to get the best effect with it. The over-the-counter products have much weaker concentrations than the prescription. If a tray is fabricated, it's important that the dental team understand that they need to fabricate it in a way that there are no rough edges. It's not impinging on the tissue at all, that it would cause tissue irritation. And as far as tolerability, the reality is patients may not be able to tolerate their trays throughout the whole treatment process, depending on tissue sensitivity, depending on nausea issues. So what we usually tell patients is, use it as directed. If you get to points in your treatment that you just cannot tolerate it, back off and just use as the brush on. And then as you are able to tolerate it again, start going back to it, just that they don't give up on it altogether. But this is an area to check for those potentially irritating ingredients in their prescription fluorides. Other considerations, there are more and more products coming out that have what's called a nanohydroxyapatite, which is another remineralization ingredient. There are options for looking at prebiotics, which that is going to help, again, feed and nurture the good bacteria in the mouth. An example of that would be arginine. And there are now oral probiotics, which basically are a little lozenge that you can suck on, and it will reintroduce healthy oral bacteria into the oral cavity. And just the same as there are probiotics for gut health, now there are a growing number of probiotics out there for oral health as well. So we'll just wrap up here with something that one of my patients, I shouldn't say my patient, a patient at the practice where I worked, she went in for breast cancer. And of course, I had talked with her before she went in. And when she was done with treatments and I saw her back the first time, she said, "Oh, Jill, I'm so scared of what you're going to find. There's so many times I did not feel like brushing. I was tired. I was nauseous. Putting a toothbrush in my mouth was the last thing that I wanted to do." But she said, I kept telling myself, just do it. My hair will grow back, my teeth won't. And that just has always been so profound to me. That is something that is so true. There is a lot of attention that is put into hair loss. And I don't ever want to discount how traumatic that is, but it will come back. If people are losing their teeth, that is a whole nother ball game. And I think if we put as much attention and much effort into oral health as we did with other side effects that are temporary, our patients would be far better. So this is my information. You are all welcome to reach out on LinkedIn, connect with any questions outside of this, and I thank you for joining us.
Thank you very much, Jill. That was so informative. I feel like I learned so much. I have a ton of questions and we only have 11 minutes left, so I'm going to get started. So here's a big question I have is, we hear from like primary care providers that they have trouble managing survivors' care because they don't know all the potential side effects or potential interactions from all the potential drugs that a cancer patient may have had or treatments. And that's constantly evolving. So does the dental team know that information? And if the oncologist doesn't know and the dental team doesn't know, what happens? Like, is the patient sort of the one who has to figure this out?
Unfortunately, this is not something that is taught in most dental schools, definitely not in most dental hygiene schools, but I think we have other outside resources now that are a great opportunity for medical and dental providers and patients to be empowered to gather this information. There are different societies, like I mentioned, the International Society of Oral Oncology, the Multinational Association Supportive Care in Cancer. There are these organizations that do the studies, they get the data, they put that all together. And truly, that was one of my goals with side effect support too, is help to gather it from these different resources, put it in one area that it's more convenient, because the reality is we don't have time as providers, to know everything either, and to be doing all this. So I want to do some of that legwork for people, hopefully to make it a little easier to access it.
Yeah, and when you talked about, having a jaw scan before treatment starts, I mean, and one of the comments in the chat was just that, the oncology team is usually like, let's get started with treatment right away. So there's not always that time. What would you say is the most important thing that survivors should tell their dentists?
I think your dentist needs to be aware of what your treatments were, for sure, because not all of the treatments, once you're done with treatments, doesn't mean that those side effects end. And a lot of people have these lingering effects or lingering risks. And I'll use that medication-related osteonecrosis of the jaw example, where there's certain medications that stay in your system for many years. So even if they aren't taking them right now, they can stay at risk. So it's so important that your dental providers understand what your treatments were, what the medications were that you took, and if you're having any problems, get that conversation going. And sometimes it does take the patient, unfortunately, to educate them, or to, if you don't feel you're being serviced well by your provider, that they don't understand or appreciate the problems that you have, you don't have to stay there. You can look around for another provider that you think is a better fit for you.
And since care planning is something that we focus a lot on, if you had a care plan that you could bring to your dentist that shows exactly what your treatment was, that would be very helpful.
Very helpful.
What is the connection between chemo and steroids and teeth crumbling?
A lot of times steroids are used in conjunction with chemotherapy. Steroids many times can mostly affect like support structure of the teeth and have more of an effect on your periodontal health, because we all have a bone that's holding our teeth in place that can actually recede down. So you may have somebody that's never had a cavity before, but if they lose that bone support, they can have tooth loss because of that. So typically, it's a cascade of things. These medications, if they lead to dry mouth, well, the dry mouth makes the oral microbiome different. So then that makes them susceptible to the decay. And, it's not necessarily a one thing. It's a combination, unfortunately. So it is sometimes just taking those simple tips and trying to put that all together to manage one thing, and then hopefully it'll help to manage other issues too. I don't know how well that answered that, but that was a tricky one.
Okay, can you talk about the risk of jaw necrosis from bisphosphonates? And there's more to start with that.
So bisphosphonates are a medication that's given to help maintain bone integrity. And we have certain cells in our body that tear down bone, and we have certain cells in our body that build up bone. Just like that remineralization, demineralization of teeth, our bones are doing that all the time. So what a bisphosphonate does is it kind of interrupts that process, where it doesn't allow for the bone to tear down. So as this bone is building without interruption, it sometimes doesn't form the same vascularity. It doesn't have the same blood flow. And then it can be susceptible to not having the healing ability. So osteonecrosis, if you break that down, is considered death of the jawbone. So that is something that, especially if we know somebody's at risk, we need to be very preventive with them, because the vast majority of osteonecrosis cases are caused by some type of trauma to the bone. So whether that be an extraction, something that has traumatized that bone and now it doesn't have the same healing ability. So if somebody's going to be getting a bisphosphonate, or they're getting one of these other medications that are considered like anti-angiogenic, something that prevents blood vessel formation, because blood vessels can play a role in cancer spreading. So it's one of the ways they can help to treat that is by reducing the blood vessel formations. If we know somebody's going to be taking that, that's where we need to know, is there a tooth that may need an extraction? let's get it out of there. Maybe if it doesn't have a good prognosis, we might want to extract that tooth before they start the medication. Because especially with the bisphosphonates, that's one of the meds when I mentioned that they can stay in your system for a really long time. Some of those can have a half-life of like 11 years. So it's a long time that a person can stay at risk, and we need to be very preventive, keep everything as healthy as possible for them.
Is it better to save a tooth or pull a tooth? There may not be a single answer to that question, but
in general, it's better to save it. Every time you take a tooth out, it causes a cascade of issues because the bone that holds teeth in, if a tooth is not there, it will recede down. If you have a tooth, if you have teeth in a row and you take this tooth out, they will collapse in. They try to fill the space. And now when these, the ones on the bottom would close in to fill the space, now the top ones might start growing down. So when you lose a single tooth, it can affect everything else around it. So in the ideal world, yeah, we'd love to save them. The reality is it has to be on an individual case-by-case basis, that if you have one that is has infection, you're on a timeline, you can't save it, then we need to just look at, we need to outweigh the risks and the benefits. That's always the thing. And it's very individualized.
Are there dental procedures like root canal or others that are risky for people who are immunocompromised?
Anything that can stir up that bacteria, if your blood counts are low, and that would be mainly your white cells. If your white cells are very low, you're going to be at much more risk for developing an infection. An infection that happens in the mouth can spread to other areas of your body, and also with your platelets. If there's an invasive procedure that's done and you don't have adequate platelets, that could cause a bleeding issue. So if you are in treatments and you need to see a dentist, it's important that you have your blood counts tested within 24 hours of your visit. Or your oncologist may say, okay, we know your blood counts are going to be going up and down during this chemotherapy process. If you need to see a dentist, this is the window when you should see them, and work with your office to make sure that you are being treated safely and having good blood counts during the process.
So are there certain types of cancer treatments that are known for significant dental issues?
I think most of us automatically assume it's head and neck cancers, and that is true. I mean, anybody that has their treatments localized to this area, they have, they're most susceptible to problems, but it really is across the board. And one of the things that I noticed too is that when I mentioned in the beginning, when questioning patients and seeing a lot of patients had damage under their oral health, some of them didn't even make that connection at the time that, oh, I wasn't thinking about having this problem at that time. It was just one extra thing I was dealing with, but they didn't realize how that dry mouth affected one problem that led to the next. So yeah, head and neck cancers, definitely. But now that we have these other medications with the medication out of osteonecrosis of the jaw, and different problems like that, it's pretty across the board that it can affect one way or another.
Thank you. Sorry. Okay, so can chemotherapy and immunotherapy cause continued mouth dryness and contribute to gum recession after remission?
Many people will notice through survivorship that they do have some lagging issues, but there are so many medications. I would guess for most people, when they are done with their chemo, they're probably not completely medication free. They probably are taking other medications, and sometimes we don't even think about things like, are there anti-anxiety medications? Are there antidepressants involved? Are there pain meds that are involved? Different things like that. A lot of those all have dry mouth as a consequence, and even over-the-counter medications like allergy meds and things like that. A lot of them have dry mouth. So unless that patient is completely off of every other medication, it's hard to say if it's still from that original treatment, or is it a combination of that and these continued treatments that they're receiving.
Great. Thank you so much. I'm going to end on what maybe is an easy one, hopefully. You showed a bunch of toothbrushes. Do you recommend electric toothbrushes?
I do. I think the same thing needs to apply, that using a compact head, an extra soft bristle, And then also one that has multiple modes of intensity. So there's some that when you turn it on, that's just all they are. But there's others that they may have like a gentle mode and things like that, that way they can adjust it to what they need. But then again, depending if their tissue just gets too tender, they may need to go to a manual brush just to be that much more gentle during those process. But in general, especially into survivorship, the electric toothbrushes are great.
Great. Thank you very much, Jill. This has been incredibly informative. I want to thank the NCCS team for putting this together for us. And we will be sending out the recording and Jill's beautiful slides. You have wonderful slides. Thank you so much for your time. And thank you to everybody for joining us today. Hope everybody has a great day.
Thank you.